Good morning to one and all. I am Dr. Tyagarajan, Assistant Professor from the Department of Pediatrics. Today, the topic of discussion is about approach a child with acute watery diarrhea. So, the synopsis we are going to discuss is definition of acute watery diarrhea and what are the etiopathogenesis and how to approach a child with the deaeration and assess and how to classify the child with deaeration, and also about the diagnostic workup in a child with diarrhea and what will be the management in a normal child as well as in a child with SAMI, that means severe acute malnutrition. So definition, acute watery diarrhea, that means a child is having loose stools. Loose stools means there is a consistency in the passing of stools, as well as there may be increase in frequency, that is more than 3 episodes in 24 hours, with may be associated with fever or may be associated with vomiting, and it will be lasting less than 7 days or less. And then the passing frequent passing of formed stools is not diarrhea, and the babies only on breast milk may pass loose pasty stools, but it is not termed as diarrhea. So any child with passing stools, change in consistency of stools, that is watery or liquid, or any increase in frequency that is more than 3 episodes per day, then the child will be termed as acute watery diarrhea or acute diarrheal disease. So what will be the causes of acute watery diarrhea? Among the multiple causes, infections is more prevalent in the children. So among the infections, virus will be the more prevalent cause for the incidence of diarrhea in children. So followed by bacteria and followed by parasite. So virus account for 60%. Among the viruses, 60% of viruses, rotavirus will be the leading cause of diarrhea in children, and it will be the fatal cause of diarrhea in children. So a child will be with diarrhea may be having a loss of water, that will lead to dehydration as well as dyselectrolytemia. That will discuss out how to manage a child with the dehydration as well as dyselectrolytemia. So any child presenting with diarrhea will be the complication of diarrhea is dehydration. So how to assess a child with diarrhea and how to identify dehydration and how to classify them and how to manage them, we will discuss in this topic. So the primary assessment involves the child should be assessing the general condition of the child, and you have to assess the dehydration state of the child, as well, like that includes skin pinch up test, as well as sunken eyes, and a child thirsticity, whether child is having the thirsticity or not able to drink water. Based on this status, we'll classify diarrhea into 3 scales. That is severe dehydration. That will be the most life-threatening condition. So the severe dehydration means at least 2 of the following should be there. Either lethargy, a child will be unconscious with shrunken eyes, or not able to drink poorly, or not able to drink at all, or skin pinch goes very slowly, that is taking more than 2 seconds to reach the normal state. That is called severe dehydration. So some dehydration means at least 2 of the following, that includes the child will be irritable or restless with shrunken eyes, and there will be increase in thirsticity. Any among the 3, any 2 of the following is there means the child is having some dehydration. And in no dehydration, child not having enough signs of that some dehydration or severe dehydration, and child will be having thirst, and child will be taking orally. So based on this clinical features, we'll classify the child into no dehydration, some dehydration, and severe dehydration. So next, how to work up in a child with diarrhea. Mostly diarrhea is infectious causes. Among that, it will be viral cause. So there is no specific investigation is needed to diagnose a child with diarrhea. But in order to identify the complications of diarrhea, we will do the certain investigations. But that includes you have to assess the hydration status, and then renal function test, and assess serum electrolytes and blood glucose level in case of severe dehydration. But investigations are required in certain cases, like child is having dysentery like symptoms, that is diarrhea associated to blood stained stools, or in case of child is having immunocompromised state, or child is having severe acute malnutrition. In this under any chronic condition, we will have to identify the cause of diarrhea. So how to manage diarrhea? So diarrhea is not a problem, but you have to provide adequate hydration during the episodes of diarrhea. But it will leading to certain life-threatening complications. The most common among them will be dehydration, followed by metabolic acidosis and electrolyte imbalance, as well as sepsis. These are the life-threatening complications of diarrhea. So the mainstay of treatment for any diarrhea in children will be oral rehydration solution. That will be low osmolarity solution, that's 75 millimole of per liter, that is WHO recommended. ORS is the first line of management in case of any child with acute watery diarrhea. So based on the symptoms, we'll classify severe dehydration, some dehydration and no dehydration. So the plan A is for treating a child with no dehydration. That means the child is having body water loss of less than 5%. That is, estimated fluid deficit will be less than 50 ml per kg. So the main management will be at the home-based management. Home-based management with the fluid therapy, which includes home-based liquids as well as oral reaeration solution can be given. So based on the weight, will give oral reaeration solution, that is 10 ml per kg. So if child is very young, like less than 2 months, means will give 2 to 5 spoons per purge, that is loss. And for 2 months to 2 years of child, 550 to 100 ml per every loss. And age 2 to 10 years will give 100 to 200 ml at every loss. And followed by you have to assess the child's signs and monitor, like any signs of vomiting and any signs of dehydration or any blood in stools you have to assess. And if it is after assessment child is going to any other state like some dehydration or severe dehydration, means you have to change the treatment plan as per the recommendation. So in a child with some dehydration, that comes the plan B. Plan B means there is a percentage of water loss is 5 to 10%, that having the estimated fluid loss of 50 to 100 ml per kg loss will be there. So in this plan B, the mainstay of treatment will be oral reaeration solution. That will be hospital based management, and we have to admit a child and we have to give the oral reaeration solution, that is 75 ml per kg over 4 hours should be given. And you have to assess after every half an hour for the first 4 hours, and after 4 hours also you have to assess. After 4 hours child is having adequate hydration and goes into the no dehydration statements, we have to change the plan A. And if child goes to severe dehydration statements, we have to change the plan C. So the plan C is that child is having severe dehydration, that is percentage of water loss is more than 10%, and the estimated fluid deficit will be more than 100 ml per kg. So in this you have to definitely admit a child and you have to give intravenous dehydration. That includes the fluid of choice will be ringer lactate as well as normal saline will be the fluid of choice for giving intravenous dehydration. So fluids for infant, the total fluid loss is 100 ml per kg. So you have to give the 100 ml per kg, but it differs for infants, that is less than 1 year and more than 1 year. So for infant, will split into 30 ml per kg should be given over 1 hour, and remaining 70 ml per kg will be given over 5 hours. So the total duration to to correct the dehydration will be 6 hours in case of infants. For any child more than 1 year, the 30 ml per kg will be given over half an hour, and 70 ml per kg given will be 2.5 hours. The total treatment duration will be 3 hours in case of child more than 1 year. And in the duration itself, you have to assess the child every half an hour for the first 6 hours in infants and first 3 hours in toddlers or more children more than 1 year. And if child treatment changes, means you have to give based on the hydration status. Child goes to some dehydration, we give the plan B management, and child goes to no dehydration statements, we'll give plan A management. And child is still in the severe dehydration statements, you have to provide a plan C management. So the nutrition management will be, so any infant younger than 6 months, that is you have to continue the breastfeed and not to introduce any diluted or modified formula. And regular oral feeding should be given for any child with to correct the dehydration. In case of SAM children, that is severe acute malnutrition, you have to give reaeration solution, but it will be having certain changes in providing the WHO recommended ORS. So on home-based fluids, that includes vegetable soup or buttermilk or yogurt drink with salt or lemon drink or coconut water can be given to assess a child with plan A at home-based management. Next will be providing zinc. Zinc will be given for the dosage of 20 mg per kg for 14 days, and for child more than 6 months, and child less than 6 months will be given 10 mg per kg for 14 days. So why you are providing zinc means it will reduce the duration of diarrhea and as well as severity of diarrhea, and it will prevent the further episodes of diarrhea in the next 3 months. And probiotics will be giving to reduce the duration and intensity and severity of diarrhea. The selected probiotics will be lactobacillus or saccharomyces. So any one of the probiotics can be used to prevent to reduce the duration of diarrhea. Antiemetics based on the symptoms, if child is having vomitings, will prefer ondansetron oral syrup or can be given IV as well. So, and vaccination to prevent diarrhea will be rotavirus vaccine and measles vaccine or used in national immunization schedule to prevent diarrhea in children less than 5 years. So antibiotics generally not recommended in case of diarrhea, but it will be recommended in young infants less than 3 months or child with chronic conditions or a child with severe acute malnutrition, or in case of severe bacterial infection or sepsis will provide IV antibiotics, or if you suspected dysentery like it may due to infection of Shigella, E. coli or Vibrio cholerae will provide IV antibiotics or oral antibiotics based on the organism. If you are suspecting Shigella means will give drug of choice will be IV parenteral ceftriaxone followed by cefixime and ciprofloxacin. For Salmonella, will provide parenteral ceftriaxone followed by azithromycin or ciprofloxacin. And in case of E-tech, that is enterotoxigenic E. coli, the drug of choice will be azithromycin followed by cefixime. But in case of Vibrio cholerae, the drug of choice will be doxycycline single dose. Next will be azithromycin single dose. So diarrhea in children with SAM. SAM means child is having severe acute malnutrition, but that deaeration should be corrected in a different way in case of say a child with severe acute malnutrition to prevent reaeration that will be leading excess reaeration that will lead to heart failure and development of dyselectrolytic status in case of child. So how to assess a child in shock? A SAM child with shock means there will be child will be having cold peripheries or capillary refilling time more than 3 seconds and weak and fast pulse will be there. So management will prefer oral reaeration solution. Solution at rate of 70 to 100 ml per kg, or it should be given for over 12 hours in case of child with SAM. And normal ORS is not recommended. No, WHO recommended ORS, and it should be diluted with 2 liters of water, and you should add 45 ml of potassium chloride solution, and you have to add 50 gram of sucrose, and you have to dissolve before, and you have to provide to the child of SAM at a rate of 75 ml per kg and should be given over 12 hours.